Meeting to order. Please note that this meeting is being recorded on WebEx. The recording will be available on the Mental Health SF website. All right.
And Kaylee, have you started the recording?
Would anybody like to read the land acknowledgement?
Thank you.
I think you would, Madam Chair.
Okay, I will read the land acknowledgement. San Francisco Department of Public Health staff acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibility as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community by affirming their sovereign rights as First Peoples. All right, Diana will now call roll call.
And we're going to do most of the logistic-y stuff later, but roll call we need to do right now to establish that we do have a quorum. So as you know, upon your name being called, please respond with here or present or some other verbal indication that you are here. Member Fields joining us online.
Yes, I am.
Member Gonzalez. Here. Member Lipton.
Here.
Member McGuigan.
Here.
Member Patterson said that he could not come. Member Salinas.
Here.
Member Short online. I think you're muted, Sarah. Oh, there.
She waved.
Oh, okay. She waved. Member Short is here. Member Wong.
Here.
We have 7 out of 8 members present, so we have a quorum, which is 7. Back to you, Andrea.
Okay. Oh, should I flip the
Are you all
page?
making noise right now because I cannot hear anything if you are.
No, we just asked if you were here to say present, and then you waved. So we indicate, we thought of that as you saying present. Can you hear us now?
Since I put my volume up, yes.
Yay! Glad it was an easy fix.
Okay.
I need tech support. Yeah, thank you.
All errors begin between the ears.
Correct.
All right, meeting goals for today. We are going to receive an update from the IWG from Supervisor Ronan. Welcome. Thank you for coming. We're looking forward to the update. And we are going to receive an update from Dr. Coonans, the Director of Behavioral Health Services and Mental Health SF, including a summary of the information presented at the residential beds hearing. Very much looking forward to that. We're going to plan for calendar now our upcoming IWG meetings. Okay, so we're starting our meeting today with discussion item 1, an update from the District 9 Supervisor, Hillary Ronan. Welcome. Thank you.
So much. Thank you so much for having me. I'm very excited to be here. I was together with Steve Fields and Sarah Short, one of the authors of Mental Health SF, which we passed in 2019, in December of 2019, right before the pandemic, unfortunately, to really reform our behavioral health system in San Francisco. What we saw at the time and continues to be a problem, although much less so, we're moving in the right direction, is that San Francisco has a number of amazing programs, but that are often really disconnected from one another, and that we did a better connected system of care in order to really effectively serve people suffering from mental health or addiction illnesses. And so we met with many of the frontline providers over the course of a year to author mental health SF, including member Wong and Salinas, to really understand what it would take in order to build a functional behavioral health system in San Francisco. And what resulted was mental health SF, which passed unanimously before the board of supervisors with support from the mayor. It was a very political fight. You know, the original version of mental health SF included everyone, not just you know, the indigent or severely mentally ill, but a compromise, which is always the case in politics. In order to get unanimity of support, we, you know, really focused it on the most severely mentally ill or sickest people in the streets, and that are dependent upon our you know, safety net here in San Francisco. I want to thank you all so much for your service. The IWG, you know, was meant to provide input and oversight into the rolling out or the implementation of mental health assessment. Of course, that unfortunately was delayed by a year because of the pandemic, which was a must, obviously. The Department of Public Health had never been more overwhelmed, and the focus was rightfully on preventing deaths during the COVID and pandemic crisis. But it did take us back a year. And so we've always been a little off on our timelines and all of that. And so the reason that I wanted to come to you today is because, you know, in real life, the way that mental health SF has evolved, I wanted to suggest that we make some changes to the IWG for the rest of its existence, to focus it and to make it easier on all of you and in your precious time, because we know how much you're giving to this body, and also how much you take away from your actual work in the community when you're here. And then, you know, there's been real quorum issues. And like anything, the IWG was, you know, formed with so many seats because of the political process, but we're past that now. And so one of the things that I had hoped to do is introduce some legislation to decrease the number of seats on the IWG. There's so many that are vacant that we just wanted to streamline it. It's also easier in smaller bodies to get more done. So that was one thing we wanted to do. We also wanted to decrease the minimum number of times that you have to meet to a minimum of 4 times a year. So once, you know, every 3 months, which doesn't mean you can't meet more, but just takes away that monthly requirement that is burdensome. We knew that and was necessary in the beginning, but probably not as much so right now. And then finally, we wanted to set some real goal, or not finally, we want to set some real goals for the purpose of this group with you, so that your work over the next couple of years is really focused. And then last but not least, end or sunset the group at the end of 2025 instead of, I think currently it's 2026. Just so that we have the, you know, we have some really clear objectives, get them done, and then, you know, hopefully move on with continuing to improve the behavioral health system. What I said at the Bentz hearing is something I want to say here. Mental health SF it's a system, right? And it's going to be, we're constantly going to need to perfect that system and make it better and improve it and iterate according to, you know, the funds that we have and the reality on the ground. And you know, the hope is that we continue to have a more streamlined, more coordinated system of care for people suffering from mental illness or addiction, so that they're not cycling in and out of, you know, from the street to behavioral or the crisis center at General, to jail, to the street, you know, that we see so much in the city. And that's going to be a forever process. But we continue to believe that San Francisco could create a model that could be the best because nobody's doing it perfectly anywhere. And we know that that's, you know, for many reasons, but we want San Francisco to be the best. And so I wanted to come today to, you know, I know Jackie, I should introduce Jackie Prager from my office. Jackie has been talking to many of you. I've spoken to a couple of you about this idea, but we wanted to hear your feedback on this plan or idea for legislation. With that, I wanted to turn it over to you. And just again, thank you so much for being part of history of making the best behavioral health system in the city and the county, anywhere in the United States. Turn it over to you. Jackie, do you have anything to add? Thank you.
Did anyone want to comment on the, yes, Steve, yes.
He's on mute.
Hi, okay.
Hi. Who else? Yeah.
I do Steve also.
First of all, it's great to have you here, Supervisor Ronan. It was an extraordinary opportunity to work with your office and with you in particular around actually addressing the legislative and then the administrative rollout of a system of care that we all knew had many gaps in it and needed some direction in order to move forward. And Mental Health SF is a unique piece of local legislation around the state because many counties have less resources and even less of a vision of where they think their behavioral health system is going. And I think thus the consequence of that process in the county-based systems has resulted in this return of the infatuation with involuntary care actually producing credible outcome results for people who are struggling with severe mental illness, substance use, and certainly people who have the concomitant challenge of both. So I think that, and I want to thank you. And I'm hoping that we can continue to discuss a way in which there's a continuity of your leadership to some members on the board who I know have been engaging in this complicated challenge we have for behavioral health. But the most important thing, and you expressed it at the hearing on Wednesday that was held by Supervisor Mandelman or called, we have to talk about a system of care. We have to talk about not just responding to the failures of our system, but look at why people are on the street suffering so much and cycling in and out of emergency care. And if we don't look at that, we will continue to have a group of individuals who are presenting the kind of symptoms that Supervisor Mandelman has called out so eloquently, who demand higher and maybe even involuntary care. But they didn't start there. And from an agency that has dealt with diversion and seeing people through the last 40 years coming through our acute care system, there is no doubt in the stories we see of the people who come in for our services that there were steps along the way where a more intensive, more structured intervention could have prevented them from reaching the kind of desperation and situation that we see on the streets. And the role of San Francisco General Hospital is an important element in that. So there's so much more to do, but we're on the verge of it. And I just wanted to say I appreciate this, your work on this. I hope you can continue to help us link to a legacy of some other supervisors who may carry a similar commitment to developing a system of care that's coherent and has an outcome as a system, not just individual programs, so that we can continue to work. A lot has been done. And I think one of the biggest legacies is I think the Office of Continuing Care is an extraordinary result of the legislation itself, and the work that the Department of Public Health has been doing on that is going to be a major element if we can keep it focused on a systemic response. So The only thing I'd like to say about the goals, and I think it may come up, is that I'm concerned about the move to 2025 on the sunset for a very specific reason. Prop 1, if it passes in March, is going to present a huge opportunity and challenge to San Francisco. And we're going to need a close working relationship between community-based programs, Department of Public Health, to maximize San Francisco's ability to utilize Prop 1 when it passes as an engine for developing the community system of care we need, not just an engine of continuing to contract for high-end acute involuntary care. It's a big opportunity for us, and I would like to see the IWG play an important role in how that element can help drive forward the development of mental health SF. So thank you for your work. It's been extraordinary, and we hope to see you still, your voice still in the mix when you leave your position in the Board of Soups. We don't want you to disappear. So thank you very much. You've made an extraordinary contribution to mental health in San Francisco.
Thank you.
Steve.
We've not met. I'm the pinky finger on the IWG because I'm the lone member not appointed by the board or by the mayor. It's appointed by the city attorney. Since we've not met very quickly, I'm a 50-year healthcare lawyer who's just retired. Took my first 5 years working on the California State Assembly Health Committee, including the Committee of Mental Health and Development Disabilities, as it was called then, for Frank Langerman. So I'm old.
Experience
Never
of
even
lives.
gone. I just want to, first, as Steve indicated, this was an enormous undertaking and very bold. And I think the department has done a sensational job of trying to implement the various components of mental health success. There's a lot of pieces of it which are still in process, like things like the office of coordinated care and some of the other things that are going on. However, the job's not done. We have several required services that have not been implemented. We probably, if we're fortunate, will have a crisis stabilization unit by the end of the year, but it's been more than 2 years since the IWG looked at that as a design issue. The centerpiece of mental health stuff, the Mental Health Service Center, if it's going to go forward, yeah, it's going to be, I can't imagine it'll be less than 18 months to 2 years, just because nothing gets done in the city in less than that time, no matter who seems to get behind it. So I would concur with Steve about, about the sunset. And, the TAE is another one that is still in process. So there are a number of components that have not been completed. But I would definitely concur with Steve's comments that I think we need to continue the IWG. The question I have is this the proper composition going forward? This is not to make, I mean, I know that, there's been some concerns about reducing the number of meetings. I don't think you could have a better group of people that are on the IWG right now. But it may be, and I agree, I would reduce the size. I would probably prefer to have a minimum of 6 meetings a year, but the IWG decide, the frequency, but things change. And too often we've been behind because things have changed. And the first time we hear about it is either before the board or in the Chronicle or the Standard or some other source. So we probably do need to meet a little more often than I think 4 times a year. But maybe we need to have conversation among group about, and I think this person, if he goes to the composition, how the seats are allocated. I've been on the IWG now for coming up on 2-3 years, and there have been 2 seats vacant since I joined. James came in the same time I did, so he can say the same thing. If it hasn't been done in 2 to 3, 2+ years, it's just not going to happen. So it's not just decreasing the seats, but also looking to see, do we have the right composition? And I'm happy to work with anybody who wants to work on this to come up with maybe a little better kind of easy mousetrap. But I very much appreciate your coming, and I think it's a good thing for this.
Sarah,
Hi Supervisor and hi Jackie and hi everybody else. Um, here in Boston. I just want to make sure I'm clear on what's on the table. And so I heard a reduction in the number of meetings. And then, we've talked a little before, and I think that you're also suggesting a reduction in the number of members as well in the seats.
yes.
Okay, and did I not hear what those seats would be that, or
We're open.
what the remaining
Yeah.
seats would be?
Yeah, we're open. I mean,
Okay,
it's easiest to get rid of seats that aren't filled, right?
Yeah.
Like, we don't want to eliminate your participation.
yeah,
So-
everybody stay sitting.
So I think that's what we were gonna look at, which seats are not filled or which seats are gonna be vacant and, and individuals are not planning on reapplying for those seats. So we were kind of looking at it that way, maybe with a combination of what actually also makes sense. So, but we haven't decided that. It's more of the concept of it. I always thought it was too large from the get-go, and it just had to be because politics. And I think we're past the politics. So let's actually do what makes sense and works best, as opposed to, what satisfies every interest group.
Yeah.
So that's why we want your feedback. So we appreciate that.
Yeah, I got that you were, that decisions haven't been made yet. And I appreciate you coming to us and asking for our feedback.
Sarah-
My just initial
Sarah,
thoughts
I
are,
should also
Oh, yeah.
just clear, there's no draft legislation yet. These are concepts, not,
Okay.
so the minute we wanted to get your feedback before we even began to draft it.
okay, great. Yeah, and my just initial thoughts are that, I mean, I'm really invested in this, this body and this process and this legislation. And, I really want to see it be effective. And for a number of reasons, it hasn't been as effective as really we need it to be. And so I really do appreciate you thinking it through and thinking about how can we, you know, be more productive. And we have absolutely had challenges with both attendance in general and then also with filling the seats when they're vacant. And so I think it's absolutely reasonable to be looking at both of these things. Everybody who's on this is like by nature a really busy person. And so, reducing the time commitment, I think hopefully would help. And then, yeah, having to sit around with vacancies and have, business like, stopped as a result it's not something we really can afford right now. We need to be like moving quickly on this stuff, and it feels like we've been lagging behind on a lot. So in concept, I endorse, these suggestions. I think we need to think through and play around with sort of the details. I really don't have a great answer for how we get around the that we have so much work to do yet none of us have enough time to commit, so that part makes me a little nervous about reducing the number of meetings because we're not getting enough done as is. But if there's other ways that we're making things more efficient, I think hopefully we can balance that out. And then it may also be, I think we can look at other things like reduce for me, for instance, reducing the time commitment per meeting, but having more frequent meetings would actually work better for me. That's just an example. I'm not, steamrolling over anyone with that, but and so looking at again, if we are gonna do that, let's look at other efficiencies we can bring, to the group and to the table so that we're still, we're not sacrificing in terms of what we're getting done. But yeah, so just overall, thank you, and let's work this out so that we can have a really good, well-oiled machine. I mean, no, we're not gonna get into that, but thanks.
Thank you.
Anybody else? Okay.
Supervisor Rowland, I'm so excited that you're here. And I think we started this journey all the way from the beginning when we started. I remember Jim Salinas as well, and Fields and Shorts.
And Anna. If you're-
I just want to, when initially, when Jackie contacted me and, saying, well, because of the quorum issue, the attendance issue, maybe we need to shorten it. And I just kind of like, oh my God, we have so much more to do. And it seemed like not too much. I mean, things have accomplished. I'm not saying that things have not been accomplished, but it seemed like there's still so much more to do. And I feel, as far as you mentioned, that the IWG is meant to have input, oversight of the mental health assessment process. But I feel sometimes the input and oversight, we have not been as contributory as much, or we have not been informed as much until after the fact. So that kind of feel, I think a couple of us kind of expressed displeasure about being respected as a body of the advisory. And I think, having only like 3 times a year to ensure, it makes me feel nervous because I'm very committed to this group. And I want to make sure that I'm going to contribute and then make a valid for the second system, and so I think, how do we do that? I'm thinking, well, okay, when we were having it virtual, maybe we can do once a month, every other month, then we can do like a virtual, maybe that can help instead of commuting here. But I think there's still a lot of work to do, Supervisor. I think a lot of it, I feel like the group has not been really in the process of partnership kind of. That's just my own feel. I could be wrong and I could be misconstrued process, but it would be nice if things have been, run through the IWG and say, this is what's going on, this is the budget. It seemed like a lot of it has not. It's always after the fact. And so I really appreciate your work. So thank you. I'm so glad you're here. I asked for you a long time.
Yeah, I think I just want to carry on what you were both saying. I think there's a lot of work to be done. And talking to Jackie, I was kind of surprised, like, oh wow, we're gonna be shorter than times we meet. And I know it is a challenge sometimes. So I guess my question is, if we reduce the number of seats, will that is quorum by percentage, or do we still need a number, right? If by percentage, okay. So I think that's a great idea, right? Because then we'll have more opportunities for quorum and be able to just kind of fight through what we need to get through. And maybe meeting a required meeting every other month in person, and then maybe doing smaller, quicker, bi-weekly, or like, hey, this is something that's coming up. We need everybody together on a certain day. Maybe have one day a month or every 3 weeks. I don't know what it is, but I think that there's a lot to be accomplished in taking away the meeting times. I know it's tough for everybody. It's going to be counterintuitive, but I definitely think paring down the seats to get the number of quorum is essential to move things forward. But then also, finding a way that's going to make it more conducive to everybody's schedule. Getting down here is a tough thing. I mean, so maybe every other month in person, but then I think virtually, if we can, and those don't need quorum, but we're still needing to move things along, not getting things stagnated or bogged down. I think is the way to go. Is my 2 cents. I think there's, especially with legislation changes possibly coming, and and then, if things are moving, is there a reason why it would have to be sunsetted? I mean, if the group is, really starting to kind of get its foot in and making changes and helping out, is there a reason why we're sunsetting? I don't know, just kind of questions to throw out there as well.
Yeah, I think the thinking on our part was, the smaller, more focused and more urgent the group, the more that's gonna get done,
Yeah.
actually.
I think-
And so, and that was the thought there, but that's why we're getting the feedback. Yeah,
Yeah.
we
Yeah,
wanna,
finality, you
we
wanna
don't
get
wanna
something
have
done.
that much time. We
Right.
want urgency.
Okay, understood.
But yeah.
I second that, like, wordingly, like, I totally agree with that. I think also just to give a brief, we should really look at, the seats and representation and also ways in which we can, reduce the burden on. It's a huge time commitment and but I have the privilege of working here and it's easy for me, but for other people, it's much more difficult. So, think ways to, make it easier.
I will give my thoughts now. I think definitely we could concentrate on membership, right? The membership, right? I think on the one hand, some of our meetings haven't been completely substantive. I think we're getting like report backs and at such from programs and so that it begs the question, do we need to meet every month? And so that we would have to do a kind of also a fundamental sort of restructuring of the content in order for to maintain monthly meetings. I like the idea of maybe every other month with maybe working groups if things arise. I think that was a really great suggestion. And that we think about like what's more substantive content for us to be reviewing rather than just having people have to come in also from their busy schedules to provide a report back on something just to have us have something to look at and to review in this meeting. And I think that one of the things that I was hoping for that I know it took a lot to get off the ground was the hiring folks to do data, right? And so now that we have, I think finally, right, Dr. Rickman's folks who have finally been able to be hired, what data are we collecting? Is there opportunities for us to suggest data that would be useful for us to be able to review outcomes of programs, not just programs that are created since mental health has stuff, but because part of what we have talked about, I think that part of one of the aims of mental health as stuff was to try and create a more cohesive system of care, right?
Yes.
And I think that we continue. There's been lots of things that have been created by mental health as stuff or that are in the works that are definitely very useful programs, but I still think that for providers on the ground, we still feel like everything's very siloed, right? And that we're knocking on a lot of doors and they're closed still. I sit there, Citywide got a new building now. All of the supervisors sit together, so we're like, so we can all lament about what our staff are going through, and that it's crazy that you have someone that you can get in to no door. There is no door. They've been denied services everywhere, or they're too acute, or they're not meet criteria. It's just, and so we continue to have this issue where no one wants to help our clients. And so
I want collected so badly.
so we continue to have these issues. And so, and I remember that I was looking, I know in my old binders, I always had a copy of the ordinance and I didn't have it. But I remember that there was a piece of the OCC that was also supposed to look at it's sort of an accountability or a overarching, a staff that were kind of had a role of looking at folks that were falling through cracks and where that we're looking at, I can't remember exactly how it was written in the ordinance, but a component of the
That was
OCC.
the private healthcare system.
Oh.
We've never implemented it. And
Oh,
there is a question of whether or not we should remove that from the law. I still think it's a brilliant idea. The problem is we just need the resources to get something like that. So just to remind everyone, that was a separate part of mental health assessment. So that was, the fact that the private system, the insurance system, doesn't provide adequate mental health or addiction care. And so we wanted the city to have an agency to sort of collect the data about how the private system is breaking the law, because there is mental health parity. And also that there were staff there that could help people in the private system advocate for the care that they deserve. That was sort of a compromise, because remember, we wanted mental health assessment to apply to everyone, every resident of San Francisco, because we believe that it's just not, there's nobody's doing mental health care correctly in, anywhere. And so because we made that compromise, we wanted this office to start looking at the private system. The problem is we don't have resources for it. And when we have limited resources, we want it to go to creating a mental health assessment service center and a crisis center and all of those things. And so we've always put that, the Office of Private Insurance Accountability or something, we've always put that on the back burner, especially after the pandemic. And so the question, there is a question if we should just remove that altogether and put it in a box for someone to take up at some later point. So anyway.
Okay, so I mean, that makes sense, but perhaps there can be some function within OCC around this one, if we're or with expansion of BHAC or something, that like if you have a client and there's literally no place in town for them, that doesn't make sense, right? That all the doors are closed, and everyone, relinquishes any kind of, because I think in the end, right, it's the ICM provider, they're still our client. It always, the bucks gets, whacked to us, right? I mean, we hold clients for years and years and years, and it's hard for us, we have mandates around stabilizing folks and transitioning to lower levels of care, but you can't get any of the services you need to stabilize the clients, right? And then you do end up in the situation where, you're requiring a hospitalization, you're requiring an LSAT eventually, right? And which is much more costly care. And just different, and the scarcity of beds. So will they even hold a person long enough for them to stabilize to go to a program, right? Because they don't have any beds. So, I mean, it's an endless cycle. So just looking at those situations, and also the interplay between the DPH and HSH now, particularly, we're having folks that are conserved that, the Office of the Conservator has an MOU with HSH now to house conserved clients without them having to go through the whole assessment and whatnot. But it's still taking well over a year for them to get placements, right? Well over a year. So, what is that about? There's definitely empty beds, sort of really inefficiencies of, when we often can't even get responses from HSH. So right now I've looped in Angelica with my components in order to get a response from someone. So you don't even get a response. You have to email, and there's no phone numbers to call. So you email right into the ether. And sometimes 6 months later, they're finally, okay, we received your request. And then it's another year or more after that. I mean, that's absurd, right? So there's no coordination between these systems, and they're very, very inefficient. I should stop there because it's in this place. But yeah, so I mean, those things, maybe getting data to make that we can really constructively use this time in a way, rather than presentations to have content, to have more useful content, and to start to really look, particularly at HSH, and really, and there's the whole new committee, the homelessness, what is the new? Yeah, I'm not quite sure, what their role, and what the accountability is, and how these two these two systems that should be working in tandem, and they're really not, and it's HSH is pretty inefficient. That's a whole other. That's for another body, not our body, right?
I do want to,
Yeah.
I want
Could we do, sorry,
Yeah.
could we do a time check? It's 9:44, there's 15 minutes left before Supervisor Ronan needs to leave.
We're over time, yeah, actually. It was just because I have a committee at 10 that I have to get back. But this was extremely helpful. And I think in terms of next steps, we'll take this feedback, draft legislation, and then maybe come back and or definitely give it to you to review and give further feedback.
In the interim, though, we have at least one seat that we can fill, right?
We
I
have,
like seat.
that would require, that's a mayoral
That's
appointment.
mayoral.
We do have applications waiting. What I need to do next, my next steps, are to speak with those of you who have, there's 5 of you who have your terms ending in June. So we need to discuss your intentions to either continue or not. And we'll be reaching out for that too, because we want to, that will play a role in what seats to eliminate.
Right. And I think I would note that a number of the applications we've received, I think could be useful for a few different seats. So there's some flexibility there among the folks that we have who are interested. So.
But as I look at this body right now, I'm like, this is perfect, just with these people. That's not, I mean, you guys are all.
Here, and we have no person with lived experience except for Jamil, and we've had which is a critical seat, I think. And we've had several applicants for that seat, and so it has to go to rules still, like, that seat has been open. It was only filled for the first 6 months.
Okay.
And I think there's several applicants for that.
Okay. Helpful. Thank you. Well, again, thank you for your unbelievable work. Both the work you do off the IWG and the work you do on the IWG. And it's really, really meaningful to be here and see you all in action. And we just want the group to be more and more productive and less burdensome on you all and on DPH staff on the whole system. So we think we can make better use of your time and get faster results through the system. So we're just going to refine the legislation to do that and we'll seek more input from you as we go forward. Thank you so much. Thanks again. Bye. Yeah. Thank you. We can move to public time.
Yes. So then, Chair, we're going to move to public comment on this. So Haley, that would be slide 6. And let me give me a second to refresh everything. Okay. Yeah, so now we're on slide 6. So members of the public who wish to provide comment on agenda item 1, which was the update from Supervisor Ronan, are invited to participate in 3 ways. First, I'll call on those who are here in person. Then I'll call on the participants who are joining online. If you're participating online, either by phone or by joining online, you can raise your hand, your virtual hand, and Kaylee will call on you and unmute you when it is your turn to speak. Everybody who would like to make a public comment will have 2 minutes to comment, and I will give you a warning when your time is about up. Is there anybody in person who would like to make a public comment? Okay. Nobody in person who would like to make a public comment? If you would like to make a public comment and you're joining online, please raise your hand now. I'll give it a minute for this because we have a number of public joining us online. I'm not seeing any hands raised. Jen or Kaylee, are you seeing any raised hands?
No, I don't see any.
Okay. I think we can share closed public comment.
Great, thank you. We are moving on to discussion item number 2, our update from Mental Health SF Director, Dr. Hillary Kuhn. Dr. Kuhn joins the Mental Health SF on a regular basis for updates. We're excited to hear what you have to share today, Dr. Kuhn.
Lots of luck. Hi, everyone. It was good to hear the discussion with Supervisor Ronan. So appreciate everyone's passion, honestly, and fervor to work, to continue this work to improve our systems. My agenda, and I think we have slides.
Yes.
Who's driving? Okay, great. Next slide. So main update for today is I wanted to walk this group through the presentation that we made at the hearing that was referenced earlier. It sounds like a couple of people were able to listen in. I know that the hearing was very much focused around questions and concerns that Supervisor Mandelman brought to us. So kind of listen to it from that point of view. We also worked with Supervisor Ronan's office, and she joined the hearing, as you heard. I'm also joined by a few of our staff members who are listening in today, including, just to mention, sorry, Chet, I'm going to call you out. Chet Valentino, who joined DPH just a couple of weeks ago from Alameda County in a new role as directing data. I'm not going to get his exact title correct, data and analytics, which is a new position. We've had it for a while under Prop C, but it's now hired. So welcome to Chet. Also joined by Eric Rodriguez, whom you all know, who was responsible for shepherding a lot of our bed utilization and planning analytic work, along with the controller's office. Kelly Kirkpatrick, who I assume Kelly K is, who has been also working with us on budget, finance, and bed and other service space acquisition. Next. So the agenda is what you can see on the slide. I'm going to move relatively quickly, or attempt to try to get through stuff, and of course, happy to answer questions. And you want to, what is the time check actually at the front? So I'll try to pace myself.
It's 10 to 10, and you have, I think, as far as we're concerned, till 11. Obviously, you may be not be
Let
able
me
to stick
just
to it.
tell you when I have till.
Okay.
You have to leave at 11 to get to.
All right, I need to leave like 5 to 11. Okay.
Okay.
Hospital
About an hour.
to a meeting.
But you got 10-minute head start.
Yes. Phew. Okay, so we did a lot of work, I think, trying to rationalize our many pieces of data. You have seen versions of this. I think what this presentation does is put some of the background information all in one place. So our current residential care and treatment inventory puts us at about 2,550 beds in this fiscal year. This is an estimate for the following, and is changing for the following reason. And this sort of gets at, I think, what Member Salinas is speaking about. It includes what we are terming as needed beds, which are not fixed numbers of contracts that we hold with an entire provider in county, but it is beds by and large out of county that we contract. We have a contract with the organization and we place people there, but there is the ability to say no to a client. And we estimate our capacity there by taking an average of census, essentially, over time about number of people in those beds. So on the mental health side, again, this is sort of a bit of an artificial separation. We have approximately 1,860 beds in this fiscal year. This includes both these as-needed and fixed bed counts, includes in and out of county beds, although most are in county. And as you all know, it offers a range of treatment lengths and intensities with some population-specific services focused on particular folks. On the substance use side, we have approximately 690 beds. Most of the residential substance use care is in counties through contracted providers. And similar to the mental health side, the programs vary by length, intensity, and include population-specific services. Next slide. So the next two slides are very detailed. And they describe the bed types, the number of those bed types, and the asterisks that you're seeing in front of you reflect that it includes at least some what we are terming as needed beds. So let me just pause. People have this in front of them. To see whether there's any questions. I feel like this is a group that knows probably what each of these categories are.
When I see the word residential,
Mhm.
I think of the difference between institutional versus quote residential. And residential are, to me, is a lower level of care than whether we want to call it inpatient, whether you're going to call it acute, or we want to call it skilled or something like that. And I think one of the issues we've always talked about is the variety that's what's the length, sort of anyhow, that we've got to continue. And I didn't look at this well enough, but is there sort of have we aggregated the numbers between what would be on the more intensive acute side versus what we have in terms of what would be, what I would think of being more pure residential, which is more of a step down or a lower intensity level?
We are, I mean, this is the nomen, I'll tell you how we're using the term and the reason.
Yeah.
But I don't think there's a single right answer. We could do what you were describing, I think, by subtypes on this list. We are using the term residential to mean places where people stay overnight. And they have a variety of acuity and a variety of voluntariness. So this really, and I'll tell you the reason we were interested, there's, I think Member Fields sort of described, I can't remember exactly the sentence you said, Member Fields, but something like the focus on involuntary care is really very strong right now. And we really wanted to include in sort of what we're describing as residential, to present it as, here is, as you're sort of saying, the spectrum of things that happen when people can stay places overnight. We could certainly, and I see Eric on the screen, divide things up in ways that you're suggesting. We attempt to do this by using the words emergency and acute care, locked or involuntary care, voluntary residential care, what we call low threshold care, longer term or therapeutic residences, which aren't necessarily offering licensed treatment, but are doing, there's some therapeutic milieu-based care around there. Residential care facilities, sometimes known as board and care.
Yeah.
And then all the way to what we're describing as mental health housing, where we are, heavy on the residential, light on the structured in the facility therapy.
I think that for planning purposes, if we're trying to stick together a system that goes all the way from the involuntary crisis / acute, all the way to, let's say, I guess your transitional housing or maybe more traditional RCFE or board of care, it is helpful to have those numbers sort of spread out so we can see, how best to plan
Right.
going forward, that we're getting the right complement of beds so that there is that continuum for someone who leaves a higher level of care to be at a lower level of care.
So stay tuned about the numbers. That's what's coming.
And that's really what's behind my question.
Yeah.
It's not the term residential. It's really more of a focus.
And we're very open to feedback about, how to look at when, go home and look at the enumeration here. And we're very open to feedback about communicating this as clearly as we can. This is a field and area with so much words that I think when you're in the field, you sort of, I should say, when I got here, I didn't know all these terms. These are not completely standard. It's not like, these are standard terms in the field. It's
It's a recognition that beds are not fungible. Beds are not fungible.
a bed is not a bed is not a bed, right?
Yeah.
Like, it's not just put a bed somewhere.
It's kind of like in the inpatient side, you can't put an adult in a pediatric unit,
Yes.
or you can't put
Yeah, each one of these has its own criteria.
Yeah.
I just want to also call out, just not for me, but I think I sort of had an understanding about it for the public, that it's kind of the therapeutic residences and the mental health housing, those are they sound like they're kind of the same, there's a little bit of therapeutic component. It might be confusing for people. And I don't know if there's a way of remixing that, yeah.
I don't even know what psychiatric respite beds.
So
What program is that?
we are calling the Hummingbird Psychiatric Respite. So it's respite. It's not a commitment to a particular length or program time. It's meant to have drop off near, imperfect drop off capacity, which is something to talk more towards. It's about using the term respite. We are adapting it from medical respite, which is a longer standing program in the city, I believe. So that is,
Well, that makes sense also because the original implementation of Hummingbird was literally people just went for the day when they were feeling stressed out, weren't staying overnight.
when it first opened. I see member Field, sorry.
Yeah, this might be more of a question for Eric, since he's kind of the daddy. Is there a way to get a list of where these beds are at and what facilities they fall under? I've been on here.
Yes.
Never feels probably knows me, there's two things that I kind of always push, that what gets measured gets managed. And I think that one of the black holes of all this is we have all of these different facilities and programs, but they're not measuring in a single database, right? So somebody might be a repeat or something. And it'd be great if we could get, everything siloed into one thing. And then also, I'm a big person of, if we're going to know this, and I don't work in the field as much as these people do in terms of the care. I'm more, on the fire department side, so I don't see the backside of it, but I want to see the backside of it. So for me, it's like, I want to go to field trips and see how these places work and, get a better idea of, okay, this is what we're working with or whatever. And then also, talking about shut doors, like, oh, sorry, that person can't come here because they don't fit into qualifications A, B, and C, but they fall into E. So we're going to send them there. And well, E is closed. We don't have any beds. And so, just for me to get a better understanding. So I'm a big field trip person and getting out there and looking at these places. So that's what I would like to do. So if we could get that, I would try to coordinate some field trips with anybody in the group that would like to go. But that's just me.
And I believe member
Fields.
you have your hand up?
Yes, I did. I also want to add to this in terms of, this isn't just a haphazard structure also that's been developed. There's also, for many of these levels of care, specific regulatory control and expectations and oversight of these various settings, mainly in relationship to their Medicaid or Medi-Cal status. So, for instance, voluntary residential treatment on this chart, the acute diversion, called crisis residential in the terminology of Medicaid, Medi-Cal, thank you, and the various 30, 60, 90 day, and 6 month, those are all in the W&I code as regulated, regularly visited and supervised residential treatment environments that qualify for Medi-Cal reimbursement as a part of them being the system of care. There's similarly regulatory categories for the Mental Health Rehabilitation Center, for what happens in the skilled nursing continuum from IMDs to just basic skilled nursing, and in emergency services. So some of these are new concepts. Medical respite and psychiatric respite is just developing, but they're not Medi-Cal reimbursable. So the structure of supervision and what's expected to happen there would fall under the purview of the Department of Public Health. And if they're 24-hour residences, under Department of Social Services at the state level. So there is a structure underlying this. San Francisco's been creative about adding some things to these categories, but they're not brand new categories. They exist in the context of the behavioral health system of California in general.
Steve, thank you so much for that. That is an excellent reminder for all of us. I want just to add to what Member Fields also said, some of these categories are also underpinned by federal Medi-Cal, Centers for Medicaid, Medicare Services. And so some of the both the categories and means to draw down Medicaid dollars to pay for them or not are involved there. So thanks for that, Steve. I appreciate that. Somehow between here and New York, the terminology, despite that, Steve, the terminology flies around. So I will also say that. Going to the next slide.
Sorry, just
Yeah.
before we get on that, is there a way to get a breakdown of where these beds are? And
Yes.
Yes?
Yes, we'll
Okay.
get that. We'll get to
Awesome.
that. Yes.
Yeah.
Thank you.
Yes, sorry, I didn't say
Yes,
that
okay.
clearly enough.
Okay,
Yes.
sorry.
And I wonder if what data collection in the future, also looking at where people are exiting these places too, right? So, I mean, I think that's a critical component
Yes.
about how we're utilizing. I mean, and I understand Steve's point about, right, many of these things are regulated by Medicare, Medicaid statute, but nonetheless, there's still leeway in how those are implemented. Like if you just take ADU, for example, ADU, like criteria in this city used to be within 7 days of having gone to the hospital, right? Now, the only way to go to ADU is through DUC, which is only 23 hours, right? So after 23 hours, if there's not a bed at ADU, you're out on the street. Versus maybe you went to the hospital for 5 days and you actually got on meds and were a little more stable before you went to the ADU. And how does that impact outcomes, right? Like you would think that clearly if you had a 5-day hospital stay and were on a medication regimen when you went to ADU, that you might be more successful, because we're having a lot of folks that were going there, or they're not even making it in the door. Originally, we were having folks go that used to be within 7 days, if it was less than 7 days in the hospital, you went to ADU. Then it got to be like they were diverting folks from PS to the ADU, and most of our folks weren't even walking in the door. They sent them in the cab, and I don't think it's an issue of transportation. It was actually an issue of they were not stable enough to actually go into that sort of a structured environment. And so if they even made it in the door, they were frequently leaving within 24 hours. So I mean, these outcomes, and how there is leeway around implementation. And I know you differ on this, Steve, but I think that, we have the facts on the ground. So
It's PS just for.
Well,
Yes, it's
let
like
me
that.
let me just say that there's a whole, that's one of the problems with our trying to figure out what's happened with our system of care. That being the agency that runs the ADUs, that's not an accurate representation of the way this happened. In 2019, 2018, 80% of the acute diversion admissions, and they were always running at 85 to 90% utilization. 80% of them came from diversion from psychiatric emergency services at SFGH. That was all virtually the only way into an ADU. And we filled the beds for 30 years through that relationship. It was interrupted by a policy at the hospital to stop diverting, not because people weren't getting in, not because they were walking away. We have data on people who left the program. It was a successful relationship for diversion. And when Dorigen Care was added, it added another element of diversion from the emergency room. That's what happened. The disconnect between San Francisco General and the community-based 24-hour treatment system has been interrupted, is working on various myths and relationship problems. And I think if we just corrected that relationship and worked together, the hospital with the community programs, we would see a lot fewer people discharged just to the street or to environments where they actually need structured treatment, but they're not getting it, but they can get them in on a one-day notice. So, we could then do a whole thing about where case management has failed our clients, Andrea. So let's try and get the facts from the
all the
people on
data.
the ground.
We
So,
would love, I would
thank
love
you.
all the data.
So I'm gonna, I know this is an issue that I have heard come up also, and we have not fully, and I hear the difference and complex experience in this meeting, and I would like to follow up with this. Let me push us along a little faster, only because I really want you to see the results of our and that where we stand with our sort of planning analytic work, importantly. So this is a slide on our current SUD residential types and capacity. Similar to what Member Fields just pointed out, a lot of the types of SUD care, similar to mental health care, although newer, have oversight regulatory structure from the state, and specifically to draw down Medi-Cal dollars. So also similar to the mental health side of the house, we have added some service types which do not draw down Medi-Cal dollars. So for residential treatment, it is state regulated. We are what we term low barrier SUD residential. It's kind of it's not San Francisco specific, but does not participate in drug Medi-Cal, and includes our alcohol sobering, drug sobering, and what is a shelter with wraparound behavioral health services for women. We have what we call therapeutic residences, including our residential step down program, which you all have been hearing about, which is following a participation in SUD treatment program. And then we have some things we call co-ops, which are long-term housing for people in recovery. Next slide. So the next couple of slides reviews the growth, the expansion, and I'm going to continue to push us to get to the results of the analytic work, because I really want to make sure we have a chance to talk through that. So you can see on this slide really what has happened in the context of mental health SF. Since 2020, we have opened nearly new residential behavioral health care and treatment that was originally conceived of and planned under mental health SF. We still have 44 of these planned beds to be opened. This represents about a 20% increase over our baseline count. The residential expansion plan was shaped by the 2020 bed optimization report, the mental health legislation, stakeholder input, ongoing data review. During this period, we also encountered numerous, but among them, emerging needs that led to opening of 36 beds beyond the expansion planned in 2020, including mental health, what we call transitional housing, and more residential withdrawal management. On the next slide, we put together a timeline of when things were opened. And you have been hearing about this, I know, through the course of this body. So in 2020, really in the height of the pandemic, a managed alcohol program was opened. 2021, we opened the Hummingbird at Valencia, AKA a second psychiatric respite site. And we entered into contract for additional mental health rehabilitation center or locked subacute beds. These were out of county and relatively easy to procure. 2022 saw a number of expansions, including additional contracts with psychiatric SNF, a program which really evolved from emerging needs, and some, in many cases, the ones I think that member Salinas has pointed out. This was in partnership with probation, specifically tailored to people who are forensically involved. We entered into more contracts with residential care facilities. We opened drug sobering or SOMA Rise. We opened additional mental health co-ops and the mental health transitional housing. In 2023, we opened a number of residential step-down units and residential withdrawal management that had a higher level of medical capacity. So people needing more intense medical management. And then in 2024, through out of county contract, we have opened a few enhanced dual diagnosis beds. This is specifically for people with severe substance use disorder and mental health needs. And this is, you're hearing about this really, you knew that this was planned, but this really happened in the first, I guess, 6 weeks of this calendar year. Next slide. On this slide, what we are describing, and I think some of you named this already, these are additional beds that are in progress, additional enhanced dual diagnosis, 18 beds, transitional age youth residential, 10 beds, our crisis stabilization or diversion, 16 beds, dual diagnosis, women's therapeutic residence for justice involved women. This is the project that was recommended out of the Our City, Our Home committee. This is going to be done again in collaboration with probation, and several of those beds we have just recently learned are open. We are also exploring additional, what we are calling SUD stabilization beds. The reason is that this is sort of for folks considering entering into withdrawal or management or treatment, but maybe are not totally committing to it, and this would not be Medi-Cal funded. We also, I think as the group will remember, we have funding from the state, a grant, a bridge health, behavioral health bridge housing spending plan, which is a 4-year grant. Variety of proposals are sort of getting worked through. To the earlier point about working with HSH, there's a lot of requirements that this is really housing and not treatment. There can be funding for case management or navigation, prioritizing people in support. So that work is underway.
So the residential withdrawal management, is that at HealthRight, what replaced O'Reilly?
Where are you?
On 2023, it says residential withdrawal management.
Oh, the timeline.
On this timeline?
Yeah.
Yes.
No.
No.
So when Joe Healy was closed, the same number of beds was transferred to HealthRight 360. So the total number of our withdrawal management beds stayed the same at the time. recently we opened a few additional medically supported withdrawal management beds out of county.
At a higher level, thank you for reminding me, Valerie, at a higher level of care, kind of a level of care that we don't really have in San Francisco.
Okay, I mean, that's helpful to know because we have a lot of difficulties with the health, right? Because we have to do actually the medication. We have to do the withdrawal management until they actually go, because,
And
which is.
my
infeasible for
understanding,
most if
you
you're not at
said with
ICM.
orders and the prescription, prescribing, right?
We have to prescribe until they can, they can get the meds, which takes about 12 hours after you would enter there. It takes about 12 hours till you can get meds there. So for those 12 hours, we have to care for the person
Yes. And,
while they're actually at health, right, nonetheless.
so this is intended to fill at least some of that gap.
And we get to those beds through RSOC? How do we,
Through,
no one's gonna,
through
That's it.
VHAC or through
through VHAC.
TAP. And we'll talk to,
Okay,
and if member Salinas, I'm looking to see, who's-
sorry.
Dr., do you mind just?
Dr. Pading is on.
Dr. Pading is on and hearing this and.
Oh, then just unmuted.
And just unmuted. Do you want to speak to that, Dr. Pading?
Morning, everyone. So we're working on, the Palm Avenue Detox Services and Cherry Hill Services, Alameda, have a level care. They provide on-site.
David, excuse me, can you speak up a little bit? Your volume's a little quiet.
Oh, there we go. Sorry about that.
There it is.
We've contracted with Horizons Inc., which is in Alameda and in San Mateo County. They have two facilities. One is Palm Avenue Detox, which is in San Mateo, and Cherry Hill, which is in Alameda. Both of them are in transition for developing on-site medical services called incidental medical services as part of their withdrawal management. At this point, we're still in transition. We're requiring that people would have a medical provider that can do the medical clearance and then prescribe the medicines, and then they'll go there. But very shortly in June, they expect the state to approve their incidental medical services, in which case it will be just a call for them sending the clients to those detox services, and then everything kind of all you can eat in one stop services would be available. So this program has been up and running since January. We've had really good outcomes in coordinating with clients coming out of whole person care and our street medicine services who really like this program. Member Salinas, we can talk with you offline about referrals from Citywide and how you might be able to
Yeah,
use
we
some
would
of the
definitely
services.
utilize this.
Yeah.
Because we're just sending people to the ED for the last whatever amount of time. Yeah, great. Awesome.
Okay.
Can I just ask a question? It may sound like such a stupid question. I'm sitting here and I'm hearing contract, the word contract. I mean, why are we contracting? I mean, there's resources that can be needing supported within our county. And so why are we outsourcing to other counties? I mean, I'm just kind of a little puzzled here.
So historically, so it's a great question. Historically, all of the licensed SUD has been contracted with the city.
So
And
what if,
that is different than the sort of more heterogeneous approach on the mental health side.
right, and so I'm thinking that, that was old. So if we want to be creative, don't we want to not contract? And what is it that, we can bring it back here? And so that we don't have to have our people go out somewhere else to get the services that we are intended to, what we want to maintain in our home.
I think
In our
you're raising an important, both like a pragmatic question, which is our intent is to have things in county, be able to build things which take time. And so this is an example of the out-of-county work you're just hearing with substance use detox would be ideally something we would like to have here. And that takes longer. So when you can, and so it's not one or the other. So it's not a choice. And I've said this before. It's not saying, let's not do it. We want to get the services up and would be responsive to needs that we're seeing in the city. It doesn't commit us to doing it this way long-term. And so one question for us, and for you all as a body, this is something that Dr. Pading and others and I often talk about, is how do we develop this in county?
Just want to point out that Sarah online has her hand raised as
And
well.
then I'm gonna just, and then you have a question, and then maybe we should hold the questions till the end after that. Okay, Sarah.
I can also wait to the end of the presentation. It's sort of an overall question, however you want it.
I'll make this very quick. Is there a matrix?
Wait, what's happening?
Wait, so is Sarah waiting till the end or is she supposed to go down? I think that's a.
I had said Sarah and Mr. Lipton.
Okay.
Maybe, and to go ahead and ask their questions, and
Okay.
then after we move on this slide, then we'll hold all our questions till the end, so Dr. Clemens can get through.
I should say very quick.
Wait, so Sarah was first then.
Oh, Sarah,
Okay.
do you want
Go
to go
ahead,
first?
then. Go, Sarah.
Go ahead.
Go.
I also had questions about the out of county beds, and I really wasn't sure what was reflected in the numbers you gave in terms of which are you demarcating it all when you provide those numbers, which are out of county and which aren't? I guess that's the first basic question. So go ahead and answer that.
We don't have 100% accuracy of reporting in and out of county beds. We can get that to you all when we get the enumerated bed list. What I will say is in categories that on slide or on my page 4, where there's an asterisk, in at least some of those cases, that's out of county. Where there's no asterisk, it's all in county. In other words, our as-needed beds are often the out-of-county beds. Our fixed number of contracted beds are by and large in county. And
Okay, go ahead. Oh, that in itself is helpful. I would like to see that more broken down list, if you could, for follow-up.
And we have that and can get that to this group.
Great. And then I guess my other question I'll save, but just, flag that I have another one for after the presentation.
My only comment was that when you do the list of facilities, and I know it would probably show between those that are as needed versus those who are not as needed. Can it also show how many of the beds that are treated as not as needed, beds are here or they're not as needed, are actually as needed by other counties? So it's reverse as needed. So that they're sort of on call, they're not only dedicated here, but they're also on call to other counties.
They're duplicating.
Yeah, that they're duplicating.
In county, we only place San Francisco.
Can other counties place their residents in any of those beds?
Um,
Putting aside inpatient beds where you can't turn someone away.
So we have contracts where all the beds are dedicated to us. We do have in some of our as-needed facilities in county, they do place out of county.
This is a fundamental, our as-needed beds are all in competition with people from other counties.
Yeah.
That is.
Yeah.
The problem.
There are the beds that we treat as, quote, our beds, that are also in competition because there are certain types of beds that you have to admit someone, no matter where they come from. So like, for acute psychiatric bed, you can't turn someone away based on
Their
patient
county
residence.
residents.
But on a lot of the other categories, you can't. So I just was trying to see if there's a reverse. Because if
Let-
there are a bunch of as-needed bids in other counties, there must be some as-needed bids in San Francisco. But I'll just let that one go. and
Yeah,
then you-
let
and you
us,
can look at it
I
later.
know my team is listening and we'll contemplate that question and get it coherent more than my on the fly.
And we'll all have headaches when we see it.
So then just point out that Steve Fields has his hand raised, and I believe, Andrea, what you said was we're gonna hold questions until the end.
Question.
Okay.
Okay, I'm so glad there's so many questions and you know I'll come back. Next slide. Okay, this is a slide that was very responsive to Supervisor Mandelman's question, and I think probably others about bed losses.
Yeah.
This slide represents our DPH window into this question. We did an analysis examining our own contracts, and you can see this where I'm going to spend time is on the third bullet. From fiscal year 1920 to present, 12 mental health RCFBs that were contracted with SFDPH closed or ended their contract. These included 11 in county, representing approximately 60 beds. In most cases, SFDPH transferred clients to continued care. In some cases, the facility continued to operate after the end of a contract and clients remained with that provider in care with payment from SSI. And in a small number of cases, clients were transferred to another level of care or decided to continue services. Now, what I'm not presenting today, which I'm realizing we should send to this group, was a presentation by Director Kelly Dearman, who heads up Department of Aging and Disability Services, and her staff looked at using state licensure data, losses of RCFE beds. And what she found in her analysis is that there was a very small number, single handful of beds that were decreased in the city. And instead, what they found was there were fewer number of facilities with greater number of beds. So the transition has been from smaller mom and pop boarding care to fewer numbers, more larger run by larger organizations with greater number of beds. So you can see that very clearly in her presentation, and we will get that to you.
Yeah.
And I don't have more detail than that. But I think this idea that we have been bleeding boarding care beds, at least in the last few years, does not totally stand up when the data is looked at. Next slide. I know everyone's going to have a lot to say about this, but I'm going to ask you, because I really want to get to our need estimates. We know that staffing is a significant challenge. We know that vacancies reduce effective behavioral health capacity at different times, and that it moves a lot over time, meaning as people hire, they are able to increase their capacity. We do not have these data in any systematic way. We looked during the latter part of 2023 at the mental health residential bed capacity. This is the mental health treatment residential capacity, and staffing shortage affected bed availability in this very specific sector of care by 15 to 20%. We know that some providers who have multiple levels of care under one roof do flex staff from different type of bed as needed and as appropriate in order to maintain bed capacity. But I just want to note that at different times, staffing does reduce actual bed capacity, and it is a moving target and hard to measure. Next slide. This next slide is about jail discharge, and this was again in response to some very direct questions from the supervisor. We, in speaking with our colleagues in jail health, wanted us to be sure to highlight that jail discharge planning is really multi-step process involving more than behavioral health, but in fact, as you see there, the actors include sheriff, probation, pretrial diversion, public defender, DA, us, of course. Our experience or their experience has been that wait times for services have improved significantly over the past 18 months, estimating an approximate 14-day wait, which is much improved since compared to estimates a year, 2 years prior. A lot of that is being attributed to the opening of MINA, which has been tailored to folks involved with the criminal legal system, with a good impact, among other services, but that was really cited. Okay, I want to move into the bed modeling now, where I think that there's going to be good conversation. So I think as you all know, we last calendar year and really into early this calendar year updated a bed modeling program to develop preliminary recommendations, which is what we shared with the supervisor earlier this week, and now sharing with you all and wanting, and you've heard already, I know from Eric and team, we were aiming to estimate number of beds needed for 95% of clients to experience zero wait time defined a little bit differently depending on bed type. We used quantitative modeling in collaboration with our contractor, Mosemtech. We spent a lot of effort on getting input from subject matter experts, asking for feedback, using wait time data where we had, evaluating a recent RAND analysis, which was put out in 2022, in which the Bay Area was among the regions examined. The other part of this project is to develop the infrastructure to regularly track bed utilization and bed need, optimize flow, track the impact of bed expansion investments. The challenge has been, including for this round of the project, a lot of this work was manual. And so part of our goal is to automate the next round of this so that we can do this more easily and more regularly and report back the impact. So we have boiled down really an enormous amount of work on the next slide to the following estimates. And let me also editorialize for just a second. As those of you who listened in on the hearing, I also sought to remind Supervisor Mantelman that and I think Member Fields, maybe Member Salinas had said earlier, it's not all about the beds, because if the other pieces of the systems are not working or don't have enough capacity, the residential care can't fix everything. So that was not the question posed to us, and so we didn't answer it that way, but I tried to remind us of this. So using our analytic tools, the estimates that we have come up with include a need for an additional 50 mental health residential beds. This includes a variety of lengths of stay, and very importantly, includes tailored services for clients with specific needs, including both severe mental health and substance use diagnoses, seniors, and particularly people with physical health needs, perinatal clients. I think, let me carry on. We estimate we need an additional 55 to 95. This is a broad estimate for mental health rehabilitation centers, AKA locked subacute programs. And then finally is an estimated 20 to 40 beds of what we are throwing out a new term, behaviorally complex therapeutic care. what we mean by this, I think this gets kind of to the heart of what Member Salinas was saying is boarding care like services, residential care for the elderly, which really can accommodate people with some very special needs who are our hardest to place folks. These include people who may have be registered sex offenders, people who may have been found to commit arson, people with traumatic brain injury, people with memory problems. This is not a bed number, but really a qualitatively, we need to create placement for those folks. Next slide. We believe that we need some additional residential withdrawal management, again, qualitatively for people with complex withdrawal medical needs and other health needs. We need to be able to care for people with the more successfully with the most medically complex withdrawal management needs. We also believe we've opened a fair number of residential step down. This was in some sense an imprecise estimate. We think that we can use an additional 20 to 30 residential step down. Just to remind the group, this is also known as recovery housing. This is long-term residential facilities for people exiting SUD treatment, where they participate in outpatient SUD treatment while having a safe, supportive environment to live amongst other people seeking recovery. And then we know that we need more state hospital beds. And because we don't have full visibility or little visibility into the state psychiatric hospital system, it was very hard for us to estimate how many more. We know that people in our city wait for those beds. We also know from the 2022 RAND analysis that their work showed that the access to state hospital beds ends up affecting the flow both in and out of the other beds. Let me skip the challenges slide and just go to the last slide about our strategies. So I know this group knows, we need to do better with workforce recruitment and retention. We both internally and with contracted providers, we have added a cost of doing business increase to our behavioral health contracts to try to support retention of staff. Within BPH, we are working both with our central HR as well as our own HR to implement the many citywide improvements to hiring. We also know we are expecting the controller's behavioral health staffing and wage analysis next month. This group will hear about that, and as I do. We also know that we need to be able to procure beds more nimbly. So one example of a challenge we had is our withdrawal management service had to close its doors to admission because of COVID outbreak. We needed to be able to turn on other beds very quickly because of that urgent situation. We also know that, for example, when certain bed types fill up, we need to be able to procure, and we see it, we need to be able to find beds quickly if we are to achieve our no wait time goals. So recently, and I think today, the full board is voting on this. We sought a competitive solicitation waiver, which would allow us to more quickly and nimbly procure needed treatment beds. The other aspects include data limitations. You know that we have been working very hard on that, and thanks to a lot of the folks on this call. We also know that some issues are out of local control. And I just, you're laughing. And that some of these areas really do need state and regional solutions. And then finally, I do want to highlight, and you've heard a bit from me before, is that the mayor's created an executive order to establish an SB 43 executive steering committee. And I think one benefit of that steering committee is that we are meeting monthly across departments, including from fire department, HSH, the conservator's office is chairing this along with Dr. Colfax, police department, sheriff, to really together identify both things we can improve from a workflow point of view, address gaps, and ideally address them quickly in order to get people the care that can save their lives. Okay, I made it to the end. Thank you, everyone.
So we have 10 minutes for questions. Please be mindful of how much time you take up then, so that as many people get to ask their questions. And we'll go back to Steve, who I know had a hand raised from previous.
Steve Fields, that's you.
Okay, thank you. Yeah, first of all, I was able to watch your whole presentation at the board committee meeting, Dr. Cunnins, and it's one of the best presentations and most comprehensive I've seen from a department head in a long time. I know it's a long time working. There's so many moving parts, but I really want to compliment you on the amount of clarity that's included in this report. I have some questions about choices, but I think it makes an enormous amount of sense. And I'm hoping that as we go forward, we don't have time this morning, and that there'll be a chance to unpack some of it and talk about it. The only thing I just want to put out in this, because I've been around since the earth cooled in this system, the discussion around use of out-of-county locked facilities, it sounds like I'm living through the 1980s in California and San Francisco again. And I think that there are a lot of hazards in that approach. And I've said this to Supervisor Mandelman's office, that the need is clear for a certain kind of response, but that California took a wrong turn when it overly relied on this for-profit sector. And it's kind of all embedded in what you said at the hearing and what's been brought up today. The competition for those beds is the financial model of these facilities, and it never abates. So getting access is always a transactional fiscal conversation, not a client need one. So I think, and I'd like to also say how great the couple of meetings that we've had with Eric Rodriguez has been. I think he's going to bring a take on the inadequacy of the old Bland report on around bed weights and use in a way that's much more sophisticated, which from my perspective still includes, just because somebody's waiting for an IMD bed in the inpatient unit doesn't mean they still need it. We need to be able to do continuous assessments to get people off that list. And the problem with the Bland report, he said, well, if the hospital said 50 people are waiting for an IMD, we need 50 more of those. And if you go in and do an actual interview and assessment of the individuals on the unit, they actually could go to say a Clay or Loso in terms of the IMD. So we can't just say because they're waiting for a bed that means that's the actual best referral for their behavioral health outcomes. And that's the part I'm looking forward to as we roll out this effort. So thank you.
I have to respond, Steve. I mean, first of all, thank you. And really the thanks go to this team. I just want to I am the mouthpiece, I realize at times, but this is the real result of a lot of deep thinking and work by some of the folks, not all, who are on this call today. So thanks really go to them. I completely agree, Steve, is that the model of contracting, the market is failing us. I mean, just to be very clear. So we really need to find different ways to be able to get care for San Franciscans. I just want to I hear that loud and clear, and it is filling. I also deeply appreciate, Member Fields, your comment is, how do we and we will get better at this and deeply consider this, is people's clinical status changes. I think by doing more prevention and upstream work, we can prevent some of the need, and that is really important, to not letting go of the importance of those investments. And that just we fail to imagine when people can thrive in community. I'll include myself in this. When we're taking care of someone in the hospital, you want to protect them and make, it's very paternalistic and make sure they're going to be okay. And so what ends up being imagined is a similar environment. And so that I am aware, member fields, of that bias, and we are trying to account for how we think about that and do this analytically, which is challenging.
So, but we do have 6 minutes for questions, because Hillary's stop is a hard stop, so.
Anybody else have a question? So I think one thing I wanted to just around the RCF beds, if they were looking at the fiscal year 2019 to 2020 to the present only, I would definitely say that we have seen definitely a stabilization. And that if we really wanted to adequately look at the loss of the RCF beds, I think we need to go back to 2014.
Got it.
That's when we really saw 2014, I would say, to 2016. And large and like things like Parkview and stuff that closed that were huge. And so, because I think they've really kind of
think it's stabilized?
It's stabilized, but it's stabilized, after the loss of all the beds back then. So to get an accurate representation of the differences, and I know that RSAC has that data. I feel like I've been told that many, many times by them.
Let us take that back. I know that we were not, this was in response to the hearing, trying to do this. We were not able to go back further, but let me take that back. I will, if I can, just also respond and kind of gut check this with all of you. Is our team's feeling is that generic, I don't know if that's really a word, RCFE beds are not the challenge. It is really beds, that level of care that will accept, I think it's exactly what you're talking about. So just sort of blindly expanding that level of care is not something that our team believes will move the needle. It is very specifically securing slots, beds that will get at some of the hard to place folks, where, again, reflecting on the market, will decline to accept that person. And that's the kind of services we are in need of.
Yeah, and so that was the second thing I want to say. I really appreciate that they're looking at beds that will, particularly for folks with TBI and more complicated health needs. Also, it's very difficult to place folks that are not ambulatory when they're not seniors. Those sort of things that we really have huge difficulties with. And particularly that nothing really exists for folks with TBI. Those programs just don't exist. And also potentially folks, if there's a possibility for wet boarding cares.
Wet boarding cares, yeah.
Yeah. I think that there was, there was programs that were a little more flexible, West Side Lodge, and I can't remember, there was that father-son duo back in the day that had a boarding care that would also have respite beds even in the boarding care that were very helpful at times for placing folks. And then I'll put you on. And then the last thing is just, I'm wondering how Epic is going to change our data collection and I understand the platform's still being created for our programs. And if, what sort of data collection can be built in to also for reporting for us, like just checkbox, and quick fill-ins for things around outcomes for all these different programs.
Lasting thought. I've always been impressed with people I work with who could look over the horizon to see what's next. I think Steve Member Fields raised a very, very important point this morning. That if was it Prop
One.
one passes, we're gonna have an opportunity to tap into that. And that the city needs to have a plan. You're in a great position. You've got a governor who came from the city. You've got the chair, you've got one of our state senators is a chair of the budget committee now on the Senate side. And you've got some real good opportunity here. And the police department and city have to really be together in trying to figure out how best to tap into to what will be new funding. And just not be behind the curve. And I suppose that if it passes, we've got probably a lot of questions going forward, at least from me, about what are we doing to be able to tap into that.
Yes.
For sure.
Yeah.
I think that's probably the last amount of time we have. Sarah, you're muted.
Go for it, Sarah, and you're muted.
Okay, relatedly, this is happening a lot where people are passing new measures and such that require providing treatment or housing, and we are already struggling with capacity. So I'm curious as well about Proposition 43 and how, the implementation and how that's going to impact this. I saw you alluded to that. And then, additionally, Prop F on the city ballot might very well pass. It's expected, estimates are from HSA, there's about 5,000 CAP recipients and 20 to 30% of them have substance use disorder. We're looking at 1,000, 1,500 folks who are going to be required to attend treatment. And so in both of these cases, I'm curious about sort of what pressure that puts on our resources, what some of the solutions might be for expansion, quick expansion, including how much we're going to be looking, more at out of county. And then also what this means for, sort of prioritizing if we have certain measures passed that require treatment or services of some sort, who might get bumped, or how is that determined? Is it about, okay, we need to create more for this new flow coming in, or is it, those kinds of things? And also just want to, I guess, us to look at this through the lens of, a caution around as these things are being proposed. They often turn out to be essentially unfunded mandates, right? And then we're stuck holding the bag as a city for, trying to do good things, but without any resources. And so I guess I'm just going to put a plug in that I would hope that DPH and the city, when it comes to statewide measures, can, communicate that clearly when these things are being considered or proposed, that, hey, here's the reality. We don't have, what it's going to take to fulfill that requirement, and therefore this needs to come with the adequate resources. And here's, now this is good. We're getting to a place where now, we can say explicitly, and this is where the gaps are, and this is what we would need to make that happen. And I think it would be good to do that kind of analysis for any, kind of proposed legislation like these, the ones I mentioned. And I'll hand it to you. Good luck with that.
Good luck with that.
All right, well, you gotta dash out.
I gotta dash out, thank you.
Yeah, thank you.
I'm happy to, come back, answer questions, thanks. The team is as well, and I really appreciate everyone's thoughtfulness. It's very helpful to hear people's
Great
questions.
presentation.
Thanks.
Thank you. Yeah. Thank you, Chad, Eric, David, Yunjong. I don't know who else might be adding there. Lots of our folks, yes.
Is there a chance that Eric might be able to answer a question? I don't know if
Eric,
need to go to
do
it.
you have another minute to answer a question?
Sure, I can stay on for a minute or two.
I just have just a follow-up, the request on getting the, where the beds are located or what facilities. When would that come from you, or do you know when we might be able to see that?
Yeah, that would come from me. I'd want to check in with Hillary on timeline, but we do have a lot of that preliminary data already collected, including whether or not facilities are in or out of county.
I think things like address verification take longer than you might think, so.
I mean, I don't think we need specific addresses, which.
I'd like to know what the facility is and where they're at.
Yeah.
I do.
The specific addresses, yeah.
Yeah.
I mean, RSOC has all that, right?
I know, I'm saying that it should be,
So
I mean, if they're pulling that, it should be.
We do have in and out of county, we have names, specific addresses of facilities do sometimes change from like when they were created with the contract and stuff like that. So making sure that kind of thing is current would potentially take us a little bit more time, but we do currently have in and out of county. We have the name of the facility and the number of beds in each, or estimated if it's as needed, but it's, yeah.
So RSOC has all that, and RSOC, right, people from RSOC are supposed to be visiting those sites monthly.
Sure,
They should
yeah,
have
it's,
addresses.
yes, there's different ways of pulling these data together, and RSOC isn't necessarily our primary source, and I don't know if we want to put them through address verification with us, but I appreciate that.
I just wanted to say, maybe it wasn't clear that I had questions in my, what I had just said. I know that Dr.
She had to
Cummings-
go. It was, I think
No,
it wasn't that you
no,
were
I
approving it.
I absolutely understand that, but then Eric is here and answered questions, so I just wondered if there was any of those that he could address. So this was Eric about the pressure on our, existing beds and resources from 43 and then implementation, and then also potentially from Prop F. And what DPH might be intending to do in order to meet those requirements.
Yeah, thank you, Sarah. Can everybody hear me okay also?
Yep.
Great. So as far as SB 43, we did estimate about a 20% increase in demand for our MERC beds. And so that is a part of our built-in recommendation. Of course, it is an estimate. And so the actual impact is to be seen. As far as solutions to meet that gap, specifically from the impact of SB 43 or Prop F, that is more of a strategy question, and I think it's part of the piece that we're still trying to figure out.
Yeah, I'll just note, Sarah, I think part of the reason that if you see the last bullet on this slide, that the mayor created the steering committee for SB 43, I think is to have a interdepartmental approach to trying to determine how the city as a whole meets the impact of that need. So we did, as Eric said, try to build some of it into adjustments to the model, the bed optimization model, but I think the larger strategy is a conversation that's actively happening in this steering committee now. And I don't have a sense of their recommendations of when they're issuing them.
So I'm just wondering, where we can get more information about that steering committee, and maybe we can get a presentation or report from them. But even in the meantime, just a little more information about who it's comprised of and when they meet and things like that would be great. Thank
Sure,
you.
I can send you more information on that. I am not super caught up to whether this is something that is a public steering committee or whether it's like an internal at the moment. So I don't know that, but I'm happy to get you more information.
Appreciate it. Thank you.
And as far as planning for Prop F, I think we're waiting to see the outcome of the decision. And I know that there's active conversations underway, with colleagues at HSA about the impact, but I don't believe, Eric, and correct me if I'm wrong, that we have yet tried to adjust the model to account for additional residential treatment as a result of Prop F. Is that correct?
Correct. We have not factored that into the current state of the model.
But as I understand, the benefit of this bed optimization study as compared to the prior one is that we do have the opportunity with what our contractor built for us to be able to play with the model. So we can adjust it for different inputs So once we get perhaps like more detailed estimates from HSA and stuff, we're able to change our recommendations depending on what they give us. Is that, or reconsider them? I'll defer to you.
Yeah, that is correct. That is a benefit of this edition of the bed optimization project. We are planning to run additional scenarios, and Prop F is something that everyone's interested in. So let's, yeah, as we get more information of what that impact is going to look like, it's something that we can do.
It looks like Kim's hand is up, and she is the director of the residential system of care.
Thank you. Thank you.
Yeah, I was going to just provide a response to the question on the out of county beds. So I can just give a little bit the snapshot, and then some again. So as Andrea mentioned, so my name is Yoon Jang, so director of residential system of care. So we are managing all those beds, and a majority of the beds actually. Except for the out of the county SUD residential treatment beds we just added, about the 15 to 20 beds Dr. Pading mentioned. Except for that, all of out of the county beds are long-term care beds, which means it includes a mental health rehab center and the skilled nursing facility with psychiatric care, which is also locked, and also the residential care facility which is boarding and care. So those beds are all located, not all, 40% of those long-term care beds are located out of the county. So due to the reason that the city is so compact, and then most of these long-term care facilities located suburban area or rural area. So we have actually placed our clients in 8 counties all over the California. So that's my brief answer to the out of the county questions.
Right, they're even contracting beds in San Diego now.
Right.
The client go to the San Diego.
Yeah, we have a beds San Diego, but only 3 beds in San Diego, so which is called the Cresta Fallbrook. So we try to bring those people up to the close to the actually county. So they provide a lot of it. Each the mental health rehab center and skilled nursing facility has its own specialty. So that's why we just cannot plug in random mental health, plug our client into random mental health rehab center. So we usually cross refer. We are doing cross referrals when we are getting a referral from the general hospital for the conservative clients. Not just send. We're not just sending only one, referral to the only one facility. So we usually send like a few mental health rehab center referrals so that we can speed up the transfer. Now again, and then each Lacta subacute unit is a different specialty. So we had to send actually sometimes 3 clients in the Fallbrook. They've been there like for a long time. So just Andrea just mentioned, we try to bring those at least 2 people up to somewhere in the Bay Area.
Dr. Kim, thank you so much for the clarification and additional information. I think I only listened to part of the budget hearing. I wasn't able to hear the whole entire hearing, but I did capture one comment that one of the supervisors mentioned, and I think we've heard this comment also from the public as well, and I piggybacked it one time. We do have a large facility at the Laguna Honda, okay? And that's like 1,200 beds. And I love what the supervisor said at the end. She says, well, if we have just utilized this acres of land, we can actually also rent out some of the beds to these folks where we can actually generate some money, right? And I said, wow, that is such a great concept, that why can't we start? And I understand that, we want to place people as quickly as possible and, moving along and to, support their well-being. But we do have some resources, and we do have empty spaces even in General Hospital, some of the acute units. And so I'm just wondering, when are we going to be able to look at some of the resources that we have, the existing resources that we have, that we can kind of, build on again, or relook at it. And it just that this question about lack of bed, but then yet we do have some resources, and hopefully we can actually look at some of those that what we have and how we can actually make it better for our own county, making better of our own resources, and then extend our resources to generate even funding for us. 1,200 beds is a lot. I love what that supervisor said. I mean, it was just kind of something that we have brought up every now and then in this forum as well. Thank you.
I'm not sure if it's a question for me or
I don't know. I just wanted to make a comment when it comes to bed like this. Like,
Okay.
I want to make sure that
I don't
we
think I
wanna-
have a purview to answer that question.
I know. We
Defer
brought
to
it
the
up many times,
correct
and it's just no
context.
purview to answer it. Thank you. I just have to say it. When it comes to bed, I would just want to say it.
Are there any other questions that folks had, since we have you, John, here and Eric, and Dr. Pady? Any other questions? I can't, I don't see any more hands up on the.
Steve Fields.
Fill a void, yeah.
Does he have his question up now? He has.
Yeah, I just have just a quick one, even though I don't, to alert Eric maybe to something down the road in terms of what comprehensively, I don't think we have a handle on. I would also like to know what the contract, how much money we're spending in each of these contractors out of county. What is the amount of money they're getting?
Yep.
And whether or not their contract, I'd love to see what their measurable outcome objectives are to the contract. So that I want to be sure that we're mirroring in these for-profit out-of-county entities, both the board and care sector and the SNFs, that we're mirroring what we expect of community providers in the county, which is measurable outcome objectives that link to the system of care. A classic one would be X number of discharges will be referred to a treatment or appropriate resource in the county upon discharge. I've never been able to see the language we expect of the for-profits in the SNF world and the non. So down the road, I think we ought to have that data for everything, because I don't think we as an IWG have a handle on how much money has been spent on these contracts out of county and with the large board and care providers, just to get a sense, because none of those are Medi-Cal reimbursable expenses. They're all general fund expenses. And I think we as an IWG have to pay attention to that, because part of the language in MHSF is to try and maximize when possible revenue so that we can leverage and spread services farther. And the more we just buy non-revenue producing services, it affects our capacity to what we can do for people in the community as well. So down the road, I'd love to see that kind of a comprehensive view of what we're spending and what we're asking of these facilities in terms of how they work with the system of care.
If I may, just because I think Eric's purview is on bed flow and doesn't necessarily contain things like our contracts or objectives. For clarification, Steve, the contract outcomes are applied regardless of county. So all of our contracts of certain types have outcome requirements that are set for the type of services that they're providing, and they're the same regardless of where the service is delivered. So I know your question about out-of-county expenditures, and I'm not ignoring that, but just in terms of outcomes, I just want to emphasize the outcomes that we set for our contractors are based on the type of service. They're not set differently depending on whether the contractor is for-profit, nonprofit, in-county, out-of-county. They're set, yeah, so.
I appreciate that. I just don't even know if they have expectations.
They do, all of our contractors.
Okay, and I'd love to see what they are. Yeah.
They're posted online. I'm happy to email them to you.
Okay.
Yeah, they're set for every contract and they're available online. I will make a note to share them with you, so.
Okay, great. I appreciate that.
Yeah.
Thanks, Bill.
I guess I would just want to say one thing in regards to that is that the funding structure, right, for RCFs changed, right? It used to be that this wasn't general fund dollars, right? These used to be well funded by the feds until both Bush the second cut the funding, right? And so they used to be really well compensated for their services until 2007 when the feds completely cut the funding. And so now it's up to the counties, right? The clients that are at RCF get a huge portion of their SSI siphoned off to pay the fees, right? They only have $130 of their own personal money a month left. And then the rest is coming out of the general fund. And it might be a thing that, this, again, that like we accept these budget cuts that happen at the state and federal levels, right? And it never comes back, right? And that it is a thing that maybe isn't, like we've often mentioned, we've got, Wiener, we've got, very powerful, and Pelosi, we've got these folks that, it might be that we should think about, as the departments going to them and saying, hey, this should be put back on some kind of a funding bill, right? So that's why folks have left in droves. This is a thing that we hear from our boarding care operators as they're shutting down and telling us we've got to figure out a new place for our clients, is that they used to, they don't get nearly the money that they used to get. And that's why their children aren't taking over their businesses, because they're not making enough to make ends meet, right? And it also has really compromised the quality of, the food and different, care in those programs. And so this is a thing that happened several years ago that led to then the subset. That's why the budget cuts happened then. That's why back in 2014, 2015, people started leaving because they were not making enough to make ends meet.
I appreciate that. It's I think we get a lot of questions about what sort of goals are needed for state and regional strategies around these. And so that's really helpful context to hear for those kinds of conversations, because I think we have some folks who are like, where you want to point us to try to make this better. And that's a tangible thing. Thank you. Appreciate it.
I'm very interested in that too, because I don't know about a situation where the federal government reduced funding to independent proprietary board and care. I think what you're alluding to, because board and care depend on the fees that they collect from the clients based on their SSI level of support. And that has been a political football financially in the state for a long time. And if they can't pay the level of room and board costs that the board and care requires, that's always put them in jeopardy. But I don't know of any specific. What most counties do is they develop special service packages to enhance the board and care homes with staff and medication support and things like that. That's all on the counties though, and the states have encouraged that. But these special patches, as they're called, that go into the board and care homes has been the major way that the board and care, the residential care sector has been able to survive. I also think that part of the other issue is the volatility, and very thing you've been very eloquent on, Member Salinas, the level of support needed for many of the individuals going into a board and care home, no matter how well they're funded, that they don't reach a level of being able to handle someone actively using drugs with a severe mental illness, is that they're the most selective, perhaps, element of our system of care of anyone we have, because they don't have the capacity to deal with challenges. That's what happened to the board and care sector in general since 1974, when it was an afterthought of the California behavioral health system. They didn't even think housing was that important, so board and care systems built up. But I think we have to look at very specific reasons for why people are leaving doing board and care, especially the 6, 10, 12 bed family run settings. But a big part of that is the challenge of the individuals that are being referred to them present. And when we opened Clay and Loso houses as an IMD alternative, what we found is a large number of the individuals who were in the skilled nursing block facilities had come from board and care, where they were not able to get the structure they needed. They ended up in the emergency room, they went into the IMD, and they were not welcome back for very practical reasons. So I think there's a lot we need to learn that to get rid of the myths about board and care and residential care, what that structure can do. And I actually believe what the department's doing is around looking at that level of long-term support and care for people presenting very complicated issues where they will perhaps live for the rest of their lives, but they need medical support, they need other things. I think that's the role for that level of care going forward. So it was a very interesting report to see we really haven't had the loss that we were all anticipating. Now I think we need to tailor that level of care for individuals for whom that kind of residential environment is the best thing for them in the community. So.
I think the folks on our side are here way past their time. So I just want to acknowledge that I think I do need to let some folks go.
Yeah.
For other meetings.
Thank you very much.
Yeah, so we'll go ahead and do a public comment for this section.
Yes, thank
Move on to
you.
public comment.
And thank you all who joined us. That was very helpful. I think we had already left. Members of the public who wish to provide comment.
Yeah.
On this agenda item, which is item number 2, I'll first call on those who are here in person, and then if you're joining us online and would like to make a public comment, please raise your hand now and we'll call on you when it is and unmute you when it is your turn. Everybody will have 2 minutes to speak, and I will give you a 30-second warning when your time is almost up. I believe we have an in-person comment. So whenever you start speaking, I'll start your time.
Okay, start my time. I just wanted to say, I'm really glad Amy brought up about the Laguna Honda and also traumatic brain injury, because San Francisco General is supposed to be like the only place on the whole West Coast, that does all this stuff with traumatic brain injury. And we have nothing for that. But that's something that often is, goes unaddressed. And there's a lot of room there. And I feel like I've been coming here for a long time. I've missed the past few, so forgive me. But I feel like we only get half the information we need every time we have these. It's like, well, we don't know where these places are. We don't know what they are. There's an R that I didn't see on this list, but she was saying that she was using her own terminology for these beds, and we have specific titles and licensures for all of these facilities, so we shall be kind of going with the same information. And I'd like to see some accountability. I know a lot of people that would love to have permanent city jobs, and can human resources give us some information about what they're doing in terms of hiring? Seems like it takes a really long time to get any information from the controller's office. And that's their job, budgetary and all that stuff. So I would just like to see a little more support from other agencies for this group, because this is a really great group and we see what's needed. And I feel like we don't get the information, you guys don't get the information up front. I feel like we're still going over the same stuff a lot and saying, well, we don't know, especially about what is happening in terms of in-city facilities that they're looking at. Like, oh, who's looking into it?
Thank you.
Thank you.
Thank you very much. Are there any folks, it looks like there's no hands raised. I think it's okay to move on.
Kaylee or Jen, do you see any raised hands for the folks online?
No, I don't see any.
I don't see any either. I think we can close public comment.
So I know we're slotted to have a 5-minute break now, but I'm wondering if folks would want to just plug on and finish, or a bit.
Yes, maybe a 1-minute break.
Okay.
I just gotta use that.
Okay.
Turn on sound.
All right.
I'm older, 2 minutes.
Okay, we do need a break, then we will be right back. Please try and come
Okay, Beth,
in
again.
5 minutes or less.
And while you're leaving, Macy's is closing.
And I'm gonna mute us,
Yes.
mute us. while we-
Downtown Macy's.
That in my, unofficial surveys, when I talk to people on the street, hey, where are you from? There's not a lot that are from, if I consider going to grammar school, high school, or college.
But like we have a lot of folks that are from the Bay Area counties.
I'm gonna interrupt because we do have quorum
Oh, yeah.
at this point.
All right, great.
Yeah,
Let's go.
these, I didn't buy these, this is not a city gift, we just.
Oh, So we are now at IWG. Oh, no, we gotta approve the meeting.
Yes, we're on, yeah, now we're doing, so on slide
Round for 5 and 3.
27. Right. Right, because we usually do all this stuff at the very beginning, the voting to excuse members and approving the meeting minutes, but because Supervisor Rowan and Dr. Cummings were here at a specific time, we moved all of that stuff to now. So that's where we are now.
Okay.
And then it's this and agendizing for next time, and then that's it. So not a ton left.
So,
Diana, do we have to do the vote for absent members?
That's what we're doing right now.
next. Yeah.
Oh, okay. I thought we were on the minute. Okay.
Yeah, that's what is on slide 27.
Member Short is back as well.
Oh, wait, member, oh, wait,
Make
yes.
sure that we have.
Okay, there's member
Folks for-
Fields. Yep, there's Sarah.
Hi,
Hi, Sarah.
Just so we have quorum, just
Yes.
we have procedures.
Yes.
Okay, I'm gonna go. Per the IWG bylaws, the IWG must vote to excuse an absent member. If the working group does not take such a vote at the meeting or at a previous meeting, then the minutes shall note that the absence is unexcused. Any member who misses 3 regular meetings within 12 months without the express approval of the IWG at or before each missed meeting will be deemed to have resigned from the IWG 10 days after the third unapproved absence.
And you, I believe, spoke with somebody spoke with member
Member
Patterson.
Patterson says that he is moving and was unable to attend. He did meet with Supervisor Ryan's office separately to provide feedback.
Is there any discussion before we vote? Okay, great. I will now call roll call and ask.
Actually, I'm gonna do that. I'm gonna call the roll call.
Okay, all right.
Yeah, so I'm gonna call roll call and you vote yes or no to excuse member Patterson. So if you vote yes, you're excusing him. If you vote no, you're not excusing him. Does that make sense? Everyone got that? Okay. Member Fields,
Yes.
member Gonzalez,
Yes.
member Lipton,
Yes.
member McGuigan,
Yes.
member Salinas,
Yes.
member Short, member Wong.
Yes.
So we have 7 yeses and 0 nos, so we have a majority vote to excuse member Patterson's absence. That's hard to say. Member Patterson's absence. Great.
Well done.
Thank you. So now the other approval that you all get to do is approving the January 2024 IWG minutes, which were posted on the website. So Andrea, take it away.
Are there any changes to the minutes as posted on the IWG website? Okay, so I guess we have to do public comment first?
Yes, so now is public comment for the meeting minutes. And so if you would like to publicly comment on the meeting minutes, we will first call on those who are here in person and those who are joining us online. If you're joining us online, please raise your hand now and we will call on you and unmute you when it is your turn to speak. And anyone who would like to speak will have 2 minutes to do so. Would anybody from the public in person like to comment on it? Okay, no in-person comments, and I will look to the online ones now. I do not see any online hands raised. Kaylee and Jen, do you see any online hands raised?
No.
Great, so I think we could close public comment on approving the meeting minutes and move to slide 30, which is the voting. Chair Salinas.
We will now vote to approve the January 2024 meeting minutes. Do I have a motion to approve the minutes? Do I have a second? Member Lipton
And McGuigan.
and McGuigan.
So I'll now call roll and ask each member to vote yes to approve the January 2024 meeting minutes or no to not approve them. Member Fields,
Yes.
member Gonzalez,
Yes.
member Lipton,
Yes.
member McGuigan,
Yes.
member Salinas,
Yes.
member Short. Sorry, I didn't get you, member Short.
Yes.
Thank you. Member Wong.
Yes.
So we have 7 yeses and 0 nos. So we have a majority vote to approve the January 2024 meeting minutes. And thank you, Kaylee, for your hard work with that. Passing it back to you, Chair Salinas.
We are moving to discussion item number 4, a discussion to co-plan the agenda for our next few IWG meetings. Please take it away, Jen.
Actually, I'm gonna do this part.
Okay.
Yeah, so, as I think was well demonstrated today, we really have like one or maybe two kind of big topics is really the amount of time and kind of good discussion that we can have. So staffing and wages was one that we had talked about last time. Coming this month, they would like to come. I'm
They are
looking at
confirmed for March, and I will note that I think they are now eager to get IWG feedback at that time point to help them then move forward to issuing. So I think they would appreciate your consideration for a March attendance. And I will note that I forgot to add it to this slide, but of course, in acknowledgement of the meeting optimization work group that we conducted, our team is happy to always continue to do like round robin updates, or shorter or longer as you guys see fit as well. And I should have made note of that in this slide. I apologize. Yeah.
So you said they're gonna be looking for feedback. Are we gonna get something beforehand?
I will ask them
Yes,
to
sir.
have their slides.
Okay,
Yeah.
cool, perfect.
I think we're gonna be meeting shortly to plan it, and I'll have a better sense of timeline. Yeah.
Excellent.
and then the Office of Coordinated Care SCRT follow-up, is that?
I think Heather, so when we had that great presentation from community paramedicine on SCRT, I know Heather was ready to offer to return, because you all had a number of questions that were really, I think, great about what happens next, about our transitioned role to follow up. And so she wanted to come back and speak to those in more depth. And so I think that's really just pending decisions from all of you on when to schedule that. I would recommend we don't get too far out from the original SCRT conversation, but I defer to everybody's judgment on how much you want to sign up for in one meeting. That those were probably two very meaty presentations, so I'll just acknowledge that. You know, if I can check on her availability for March if that's of interest.
Sure, and then, but, so if she can't come in March, what would be,
So the things on the future meetings, so this is a list that we've just been keeping track of everything that y'all said that you wanted to do in some meeting at some point in the future. A couple of them, the first two in the bullet, so the Behavioral Health Commission and the Homeless and Supportive Housing, whenever they do come, they would like a more like tailored ask. And so before those folks come, the suggestion is to have like a discussion group or something to come up with a set of questions. So that's probably, I mean, we could do that between now and March, but that's probably a like more April thing, and then maybe the small group meets in the interim. So if you're looking at other things.
I really want to push for the last one in that section that I requested, both of those two, the overdose
Opioid?
settlement funds and the overdose prevention plan update, because I think those are both super timely. Particularly the settlement funds, because decisions are being made, you know, now. But obviously also I'm very sort of confused and curious about what's going on with the overdose prevention plan, since it's been drafted for quite a while now and I'm not aware of any movement, but I may just not know it. So that's my pitch.
And Valerie, what is the like lead time needed for those folks to come?
I mean, I think we always have to confirm somebody's availability. I think we can have folks come next month. What I would say about the opioid settlement funds, again, is that those enter the mayor's, like they enter city coffers. They're subjected to the normal budgetary process. So we can provide an overview of like what is allowable spending under that funding and how much money and when, but in terms of how those will actually be applied for upcoming budget cycle, there will be some open questions until like the mayor and the board complete their normal budget cycle. We could have like provide an overview of where we are in that process and where there are like community opportunities to come in, weigh in at like health commission and board hearings on the budget. I'm just trying to think through practically how that would work. So, those are ultimately at the discretion of like the mayor and the board to settle on usage of within the terms of the settlement. Sarah, I don't know if that would, if that helps sort of inform your thinking about when it might be useful to have folks come, but in terms of the current activities around overdose prevention and the data that we do have there, those are active and ongoing and can really be discussed anytime, so.
And Steve, I see you have your hand up. Steve Fields.
And let me just
sorry.
to respond. I would still push for both of those because I also don't quite understand the process and how the items even got like to the mayor's budget office and what they even are and all that kind of stuff.
Okay, so like an overview, like a general overview.
Okay.
What is even being recommended and what's
Sure.
what then are they putting forward and what are the costs and all that kind of stuff. Yeah.
Sure, that's helpful.
Okay, thank you. Steve Fields, you have your hand up.
Yes. I'd like to, I thought this was a good meeting today in terms of the opportunity to explore some stuff. And I'd like to continue I'd like to have some of the questions that Sarah, Member Short, shared with us that I think are germane to our planning discussions with the department about how we put in place a system of care. So we're getting these mandates from SB 43. We're getting these mandates from Care Court. There could be a mandate for mandatory treatment if you want to keep your general assistance. All these mandates without any resources with them. And Sarah asked an important question that we didn't have time to even get to, and I'd like to explore that with the department representatives in March, which is who's being displaced. What's the prioritization for access to beds? What is the discussion that's been going on about the fact that unless we have explicit resources, I know Eric referred to the Merck beds for SB 43, but SB 43 itself is still going to be subject to least restrictive, most appropriate level of care. We can't have just one place open for that. So what is the guidance in the community if we're not adding resources quickly enough to meet this new referral demand? What is going to be done to make sure that there's clarity around prioritization for access to beds? And I think that was an important question for us to talk about, to struggle with figuring out how that would be implemented. So I'd like to see that followed up in the next meeting.
And Valerie, is that around Robin or is that a separate?
I think it's probably a worthwhile topic my computer just shut off. I will make a mental note of that. I think that's probably a good topic for Dr. Cummins.
Okay, so that could be addressed in the director's report. It seems like Steve and Sarah.
Right,
So
with time, I hope to explore.
Yes.
Yes.
I want to acknowledge Member Fields and emphasize the question. I think it's a very important one. And so thank you for your question. So
you need a plug?
I'm going to go get a cord if
okay.
you all would
Here,
mind.
do you want to use this one?
I don't think so.
Okay.
Thank you so much.
So then it seems like staffing and wages is folks who could come for sure if you are all interested. And then it seems like the two kind of to decide between if you want that one also, if we have two, are the Office of Coordinated Care, SCRT follow-up, and the Opioid Settlement Fund Overdose Prevention Dashboard. And again, thinking that probably two is really kind of the max if you want to have enough time for discussion and not stay till a long time. But again, it's your all's call.
What I'm hearing that a couple of the members are saying is a priority is understanding how the legislation that is that's on the ballot will be impacting us at the county level for March. And I think that if we're wanting an adequate discussion with Dr. Cummins, that we should allot a full hour again for that. And so I think if we already have staffing and wages, and then I think today was great in that we had two things that were substantive on the agenda with ample time to have those presentations and discussion. So we should not try and also tag in the opioid settlement funds and the overdose, the overdose prevention plan. If that's okay, Sarah, we can put that on. I think we should keep staffing and wages there. We've been waiting for that. They need our input. They're ready to come in March. And we can tag on then a good discussion with Dr. Coonens, and the OCC can come on another month, and that maybe we can try and aim for the discussion on the opioid prevention plan for April. In the meantime, we can go ahead and have a work group, particularly for HSH, if we want to have both those work groups in the next month. And that way we could start to maybe get for May, having HSH or BHC come for May. What do you guys think about that? Having just two substantive things, not trying to have
Yes.
three.
I think that's a great idea. I think it worked well today.
Okay, so we can keep the staffing and wages because they're ready to come. And it's a huge issue that impacts all the services.
Yes.
And that needs to get out to the rest of the entire VHS, right? And then have the discussion on the ballot measures.
So really like impact of policy initiatives, basically.
Impact of policy
Yeah.
initiatives. And it'll be post the elections then, so we'll know also what has passed, what has not passed, so we can have a more targeted discussion.
Wow, yeah.
Yeah. Does everyone feel okay with that?
Yes.
And then we can table OCC for now, put the opioid on for April. The opioid
Wait, sorry, you said
prevention-
table OCC for, now I thought that was the second thing that was.
No,
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 that's
the
different.
second thing.
Oh, okay.
It's staffing and wages,
Got
and
it.
then the second thing is the impact of policy
Got it,
initiatives
okay.
on the county.
Got it, thank you.
OCC can be moved to April. Maybe we can do that April with the opioid prevention,
Mhm.
the overdose prevention. It's not just the dashboard, it is a plan. There is a plan that has come down to all the providers that's now underway. And so we can talk about that. And then try and shoot for HSH, maybe for May and OCC. How about that?
I think probably both HSH and OCC follow-up will be very long conversations, just flagging, but I think you're outlining sort of the trajectory correctly.
Makes it hard to have 4 to 6 meetings a year, doesn't it?
Yeah.
I mean,
Well, I mean, this is the minimum, yeah.
No way.
I mean,
Yeah.
it's
Or the
just too much.
There's no way.
Yeah.
So who would like to be in a discussion group on the HSH, coming up with some questions? Sarah, I would very much also. Anybody else?
That should be a remote work.
Oh, yeah, that can-
It would be,
Yeah.
it would be a
It could be a
committee,
Zoom.
and it would be, would be remote, yeah.
And just asking them kind of, coming up with the just good points of topic that they
Yeah.
Right.
to see them cover.
I think. if
Yes,
it's
that would
likely-
be
I don't know if
questions
it
we
is-
want.
I think
Great, great.
that would likely involve just to help a little homework probably, because I think they would probably like us to share like their strategic plan and a couple other materials with you in advance of that group as well, just to help sort of,
It's a really,
so.
actually was in our report.
So then I'm noting that it was member Short, member McGuigan, and sorry, did somebody else volunteer for the? Members, okay, member Salinas for the working discussion group for HSH's presentation later in the year.
Yes.
And Member Fields.
And member Fields, okay.
Yeah.
So we will send around a doodle poll for time and then obviously share other material for that.
Their strategic plan.
I think
It's
they,
posted, right? Is it not
they have, I should just consult with them, of like, let them know that you guys are interested in doing this and just ask if there's anything they'd like to make sure you have eyes on when you're coming up with questions. So I think strategic plan is one, but they may have other.
Okay, just so we are answered, they already have.
They
Look at
have-
some of the answers. of-
Yeah, some
stuff.
questions are
Yeah.
probably, so
There's
they're doing,
redundancies.
because they're undertaking a lot of activity to try to like strengthen or reform their services. So I think they probably would want to make sure you're familiar with those. Yeah, so.
Valerie, is there any update you want to give on the community engagement, inter-ethnica stuff, or is?
The update is that Valerie is overwhelmed and I have not been able to roll out recruitment in a timely manner this month, and my apologies. My support was largely for the presentation that you just saw from Dr. Cummins and for a couple of our other major reports.
So you did your work, so we are ready actually to recruit, and that
Yeah,
wasn't the
so,
case a month ago when we met, so.
So the intention, recruitment is not on inter-ethnic, that's through the department to do. So that is our next major to do to roll out. So my apologies. I'm one person, I'm sorry. Doing my best here. So yeah, that's the update that I have for the moment. So
Great.
Yeah.
And as a reminder, the next meeting will be March 26th.
Now, I don't expect there's any progress in terms of appointing replacement members. But do you know, is any possibility we're going to be able to replace Hallie's seat?
So I
Which
think
is a designated seat?
And that's
I
a
think
mayor.
that at this point, given Supervisor Ronan's interest in the group, it's a conversation for Supervisor Ronan to have with the mayor's office about the direction of the group. And then I think they will want to see leadership from Supervisor Ronan on the suggested composition of the seats, and then seek, collaboration on filling them. So I do think that the intention, as I understand it from Supervisor Ronan's office, is to get your feedback and get the right composition and size of seats, and then make sure that they are filled. So
I'm asking this question because, I mean, there are a couple of seats that have been filled for 3
Yes.
years. And I had, that's the lowest hanging fruit maybe,
Yeah.
or perhaps maybe not. But we have a look out,
Yeah.
having Hallie's position open, and that would be a really valuable voice to have someone in that position back on.
I would agree.
And it should be easier to fill.
I will say I defer to the supervisor's office on this, but my guess would be that the mayor's office will want to take their lead from her process and make sure that her process to right size the group is completed before filling seats. But
But has somebody been identified
not to my knowledge, no.
for her seat?
Not to my knowledge, so.
Because that comes more from your all's end, right? Or from
It comes from the mayor,
DPU.
that's.
It would be very nice if the
If the mayor's
director
office
did
is,
it.
the mayor's office is in charge of making their appointments.
It would be very nice if instead the director used to appoint somebody and not have to go through this.
I don't know if the issue city that allows that.
I know.
So, Steve, were you speaking?
Oh,
Okay. So I think we have some things ahead of us for March and April. And you'll send out the doodle to the folks who will work on the work group for the HSH presentation. So do folks feel comfortable to move on to public comment? Take it away.
Yay. So members of the public who would like to provide comment on the agenda item that is the IWG meeting planning, we'll do it like we did all of the other ones. First calling on anybody who is here in person, and then calling on anybody who is joining us online. And right now we do not have any members of the public joining us online. Everybody would have 2 minutes to speak. And is there any member of the public joining us in person? Okay. There is not, so we can close public comments for the IWG meeting planning. And then go to the longest title of a slide, public comment for any other matter within the jurisdiction of the committee, not on the agenda. And it's the same as before. There is still nobody joining us online. So is there a member of the public joining us in person who would like to comment? So no members of the public would like to comment on other jurisdictions. So we are ready, Chair, to move to slide number 35. Oh yeah, this is, we had the discussion group as a potential, but now there is the discussion group for the HSH And so that is the discussion group that
Just
is.
send out a doodle on that.
We will send out a doodle on it.
Perfect.
Great, okay, so now, other associated body meeting times.
This is the slide that we always have on here that just gives you a list of other related things going on in the city that you could be interested in and when and where they are happening.
Thank you so much. So, thank you everyone for this meeting. Our next IWG meeting is on Tuesday, March 26th, starting at 9 a.m. at our usual location. I hope we will start punctually. Can I have a motion to adjourn?
Move to adjourn.
Second that was Lipton and McGuigan. Meeting is adjourned. Thank you.
And thank you so much, everybody, for getting here so promptly.
Yes,
That was
thank
really,
you.
really helpful.
Yeah, it's nice to get started on time and get moving.
Thank you all.
I was coming from another fire station.
Bye, Sarah and
I'm
Steve
getting late.
and Val and Jen and Kiwi.